surgeries?
Oh, I do now in a surgery center. I was at Wilmer before, and
Okay.
I left 3 years ago, and now I'm in private practice.
Okay.
And so yes, and I do surgery in a surgery center. And the good thing about the surgery center is a lot of retina specialists do surgery there, so I can use their instruments, you know, I can for my challenging cases. So that's one of the, you know, it's not super efficient, but I can do a lot of, you know, like complex cases without being, you know, hit. So
I was in Baltimore for 10 years, so I know that place fairly well.
Okay, where did you, in Baltimore City at the university, or?
Yeah, I was an undergrad at Hopkins, and I was in medical school at Hopkins, and I spent a couple years at Wilmer.
Oh, okay. Well, what year did you grad? Because my husband did the same. You know, like medical school residency, but in neurosurgery.
I was probably a little bit before you.
What?
I graduated medical school in '85.
Oh, okay. Well, he was a little bit later. So yeah, and he doesn't know anything, just Hopkins, and I always make fun of him. You know, the real world. Yeah. So, and they're doing COVID in the surgery center. We don't have to test everyone. It's just a screening. But the hospital there, they do a screening for every surgery, every elective surgery, every surgery before and after.
After? Why after?
I don't know. I think because they have some cases. So, interesting.
In Brazil, the problem is that we are running out of medicine, and we are not having an anesthetic to do our case. That's the problem we are having here. We have to stop our surgeries.
You do stop everything, huh?
Yeah. The only urgencies that continue.
Yeah. How is in LA, Professor the guy?
We're trying to ramp back up, but I think now the cases in the community of COVID are increasing as well. But we've essentially resumed a normal level of clinic volume and surgery volume.
That's wonderful.
We're not, in our private clinic in Beverly Hills, we're not doing any COVID testing.
But you do a screening, yeah, because
we'll do a screening, temperature and symptoms, whatever.
Do you need to keep the waiting room empty, or?
Yeah, we space it out. We have a big facility. So we have 8 ORs for eye, and we're only using 4. So we're using every other OR.
Okay.
That's interesting. We're using everyone.
Oh.
Yeah, part of it is too, we're short-staffed.
Hopkins before and after.
What do you mean for
COVID?
What about it?
They do tests before and after?
Hi, Soledad Cortina. How are you?
I just 2 days before the surgery.
Okay, just tell them what.
Hi guys.
Because this is my husband, Dr. Miller, one of the Human Medical School at Hopkins, like
fantastic.
And I was telling about you guys do COVID, all the cases.
They do for all the cases, for all the elective cases, 2 days before the procedure.
Yeah, that's what we're doing. I'm at UCLA now, so we test them 2 days before.
He graduated from like earlier than you.
Oh, great. Nice to meet you. Nice to meet you.
Sole, do you want to try your presentation to see that it's running okay? And you have to, I don't know, you have the mic on.
2 minutos más.
We can't hear you, Sole.
Ya merito.
Are you saying something, Sole? Because we can't hear you anything.
You have to unmute in the bottom left.
I think there's a problem with Sole's audio. Maybe Sole, you should check that.
Yeah, the bottom left.
It dies.
On the bottom left of your screen, there's a button that says mute. If there's a line through it, you need to click it to uncheck the line.
I think, well, I think Ike was around just before. Okay.
We're at the hour now, Manuel.
Yes, yes. If Ike isn't here, so if Ike isn't here, Uday, you're gonna start, okay? First, we're gonna say a few words and we're gonna presentate you and then you're good to go. Oh, I see Ike over there. I don't know if.
Yeah, he's here. His sound is off.
Okay.
Hey guys.
Hey Ike, how are you?
How are you?
Good, man. How you doing?
Good, great.
Fine.
Thank you for the invitation, guys.
Oh, thank you,
Well,
thank you.
Here.
I'm sorry I have to run to back to another meeting.
Oh, okay.
No problem.
Yes, we talk about it. So you're gonna be first, Ike.
Oh, thanks, buddy.
The life of the high roller.
Yeah.
Oh man.
So
Look who's talking here. Can I see if my video is playing here?
Yeah.
It's okay?
Yeah,
Perfect.
great, perfect.
So he chose easy cases like usual.
Yeah.
Who
So
is
we're
that?
gonna.
Hi, Maria.
So we're gonna begin. Anshi, can you get everyone access? We're good to go?
Yes, we're good to go. Go ahead, Manu.
Okay. Okay, good afternoon, everyone. Thank you for being here at the LATAM Cataract League. Today we have a very special panelists and guest, and we're hoping we have a good afternoon here, sharing some knowledge and sharing experience, challenging cases. And we want to thank everyone here to be. And Guido?
Yes, on behalf of the LATAM organizers, Dr. Marcelo Murillo, Pedro Echagüe, Manuel Nicola, and I, we want to welcome everyone to our Cataract Symposium. We are very proud with our Cataract team. It is a great honor to have them sharing their challenging surgeries and knowledge at our educational webinar. Definitely, we are going to learn a lot today. And we also want to thank Poem from Bolivia for providing us with their virtual classroom and support. Marce, if you want to begin the
Okay, we're going to start first with Dr. Ike Ahmed. You all know Dr. Ike. He's a renowned for his skills and groundbreaking work in the diagnosis of surgical treatment. So Ike, you're very welcome.
Gracias. Thank you very much, everybody, for invitation and for being here. We actually are running between our Canadian Ophthalmology Society meeting and also the World Ophthalmology meeting and this. So a lot of things are happening this busy weekend, and we're back to work. So I just wanted to share a case with you. I literally just edited this literally 1 minute before I came onto this webinar. It's a case I did on Wednesday of a patient, a young 24-year-old patient who you can see has had traumatic iridodylosis and atonic pupil and cataract. You'll see the zonules are not too bad, but we need to manage this patient's iris here. This was an injury playing actually with baseball actually here, and got hit in the eye with a ball. And I'm going to start off this case as topical anesthesia, making a peritomy in preparation for the dialysis repair. and also preparing some iris hooks, because my strategy here is to deal with the cataract first. And of course, concern for vitreous is present, so dispersive followed by some cohesive and sort of side soft shell technique is helpful. There's some synechiae on the lens capsule, which I'll release with a Coogan hook. And I'm always worried about the traumatic cases, because sometimes these capsular bags have folds and subcapsular plaques and other problems. And so far, so good. 3 iris hooks are used to position over the iris, the pupil here, to keep the iris and away from the manipulations here. And we'll just vacuum up some of the pigment on the anterior capsule. But as you'll see, and the trypan blue is placed with a sweeping motion to paint the capsule, rather than injecting it directly where it may potentially end up going behind the capsule and into the vitreous. This identifies any potential folds and alerts us that there might be a problem during capsular exit, but in this case, we're okay. Some more cohesive is used now to get rid of the trypan blue that's free. And we'll basically start with the 25 gauge aspiration bevel down, just to make sure there's no liquefied cortex, which there wasn't. It's a fairly soft lens in a young patient. And of course, the trypan just helps us to do this for exits, which of course we try to aim to be just between 5 to 6 millimeters and central to the capsular bag. Again, the zonules are okay here. So at least that's one thing we have to not be too overly worried about, although there is some superior zonular laxity. Some hydro is done, making sure the lens is mobile. And this is a young 24-year-old. I debated whether I can use an IA or whether I need to use phaco. I did end up going with the IA. It took a bit longer, actually, so maybe I should have gone with the phaco, but it ended up being okay. Eventually, we got everything out, the endoepinucleus and the cortex out, replenishing the bag with viscoelastic periodically to keep the bag formed. I hadn't put a CTR in yet because I felt the zonules were okay, and I always find it easier to put a CTR in later, although if I was worried, I would put some sort of capsular support system with hooks or with a segment or with a ring in prior to the initiation of lens removal. Ring is in. I'm just removing the iris hooks, maybe a bit early, but I had some time while the lens is being loaded. And the IOL goes into the capsular bag. Everything goes pretty smooth. Put the IOL in, and the haptics are in the bag. So we're happy with the phaco IOL portion of the procedure, and we'll pay attention now to focus on the iris. Our goal here is to re-establish the normal anatomy, reinserting the iris where it's torn to the angle. And I'm making here an incision here that's just behind the blue zone. You see the blue zone here? Just behind the blue zone to approximate the iris insertion, which would be basically just behind the spur in most cases, and just approximating where I want to go. Now, I typically like to use multiple mattress sutures. There are many different ways that have been described to repair dialysis repairs. I'm using a STC6 needle on a straight needle, important to differentiate from the ones we use for repairing pupil. And this docks nicely with a 27 gauge, which I'm using an ab external technique to dock. I like this because it really approximates where the suture will exit the eye rather than going ab interno. And you see that the suture needle has basically grabbed just a very peripheral part of the iris. We want to grab enough, of course, so it doesn't cheese wire. And then this is the art of it. Basically, you can see the arc length of the passes on the iris are shorter than the arc length of the sclera. Obviously, the circumference of the sclera is larger than the circumference of the iris root. So we make them larger, and we make sure we have them spaced apart to fan out the iris. I like using slip knots, as you see here. 2 throws in the same direction allow me to titrate the knot tighter or looser, depending on how things look, because things can be variable during the procedure there. It's looking like it's coming together okay, and I'm going to approximate where do I want the other mattress suture to go. And I'm visualizing in my head where I want the iris to be. Again, placing a 27 gauge needle through the scleral tract and docking the needle. This straight needle is helpful to go across the anterior chamber as opposed to making a curved needle. And again, you can see how I'm making the circumference pass, being careful not to cut the initial suture, by the way, larger than the circumference and the arc length around the iris itself. Again, we'll basically do a slip knot carefully to bring the iris to the incision, to the iris angle. But again, we will tie it, but loosen it up. Look, I loosened it there because I thought it was too tight. And we can tighten again, adjusting tension. This is something that I'll constantly do during the procedure to get the right tension. Finally, we'll work in the supratemporal quadrant to refixate the pupil, the iris to the angle. The ST6 needle does bend, and I like that because I can use one paracentesis, easy to access in the infratemporal quadrant to pass and dock it in. We have our final mattress suture, 3 mattress sutures to essentially then complete the iridodalysis repair. Although I haven't locked the sutures yet. They're not locked yet, remember. Now I'll pay attention to the pupil. The pupil is atonic and dilated. Don't ignore that. I see sometimes people repair the dialysis, but not the pupil. And in this case, we have diffuse atonicity of the pupil. Iris is amazing how elastic it can be and how spongy it can be. And I can quite readily bring the iris and make a 1 millimeter pupil if I wanted to here. This is our standard Cerclaz approach, double-armed CIF4 needle on a tenoproline, not the ST6 needle. Same tenoproline though. And now we're using this rolling technique, bringing the iris to the needle with the pair of the micro forceps. And this is an ideal way to do this because the needle can't move up and down in the eye as easily as the forceps can bring the iris to the needle. This rolling suture creates a nice round pupil as opposed to a basting technique. And then we'll come out through a paracentesis. And we're going to do this in four sections, in 4 quadrants, going all the way around. It does help, again, to have a double arm suture, of course. You can see this is the hairy part because I am going in the area of the dialysis, and I want to be careful not to put too much traction on this. And that's why closed system techniques, really, really being careful with our positions. This was actually a pretty compliant patient. I was actually pretty happy with his compliance under topical anesthesia with some intracameral and subcontinental lidocaine. We will then go and pass here using left and right hands, the supratemporal and infratemporal quadrants, and this will create a purse string suture. Now, certainly we could have used an iris prosthesis here. We got Kevin Miller here, his guru, one of the gurus in iris prosthesis. That would not be entirely unreasonable to remove some of the iris, but I like to keep the irises if I can. It does provide a more natural cosmetic appearance, although we do have human optics that provide a very good cosmetic appearance as well. But my first preference is to retain tissue if I can. And the quality of the tissue is pretty good. You can see there's not a lot of atrophy or TI defects present. This is tying the suture with a McAmid approach, tying outside the eye and moving the knot into the eye. And you can see I'm adjusting the tension on the dialysis sutures as well to make sure we get a good closure here. We'll lock the suture here with a second throw locking suture and then do a third throw, a 3-1-1. I like to lock these. I like the idea around different pupiloplasty approaches, but I'm not a fan of leaving it without locking it. I want to make sure the suture will not move postoperatively. Then we'll lock the dialysis sutures, all 3 of them, and cut and trim, and then rotate the knots into the sclera. We don't want the knots to be externalized, and this groove is nice because it kind of holds the suture in that groove. We're coming upon it. This surgery was about an hour and a half, I'll tell you, kind of long. My butt was kind of sore afterwards, and I'll remove some OVD manually, put them on some Diamox for the first couple of days, and some alpha agonists if I need to. This was actually the patient next day. Patient had a little bit of corneal edema. Pupils were quite matched. You can see, I thought the early result was pretty good. 20/40 vision on the first day post-op. So we're so far pretty happy, as I think he was as well. And that's basically my case that I'm sharing, and I'll post it up on YouTube later on the channel. So thanks a lot for the invitation, and happy to take any questions if there are any.
Yes, any question, please.
My video played. I was talking to myself. I don't know.
So doing it under topical anesthesia, that's especially in a young male. What were your thoughts there? There's no way I would have done this under topical.
It's a great thing. I start that way, and immediately if I have a problem, I'll just go to posterior subtenons, right? I'll just snip down on the infra nasal quadrant, pop that blunt cannula back into the cone, and inject about 0.3, 0.4 cc's, and then I'm good to go. But I start off topical. I mean, you know, what was nice, I didn't point it out, when I was doing dialysis sutures, the lids are in the way. So as I'm passing the needle through, I asked him to look down. He looked down, and I was able to pass the suture without hitting the lid on those straight needles. Sometimes the straight needles are a pain in the butt to get out of the eye because you got the lid in the way. And this way I just had, look down, Antonio, and basically he looked down and I pulled the suture out. I mean, I don't want to be bravado here, and no question, I will readily block a patient, preferably with subtenons if needed, or even general for a young guy.
Mm-hmm. I tell the residents that there's, in my head, I walk around with this 2x2 box. So you have men and women on one axis, you have old and young on the other. The worst box to be in is the young man box.
Well, it's true. And my decision is usually a topical or a general, usually, because if they're so fidgety and everything else, even a block, they're kind of moving around everywhere. And as you probably know, with this whole COVID era, I mean, for us, it's a 20-minute intubation, 20-minute extubation, right? With all the aerosol generating aspects of anesthesia. So we really pushed them to do local, and we got away with it, I guess.
That was a beautiful result.
Yeah. Kevin, you for this case, you can use an iris prosthesis. Do you prefer that kind of thing?
So I think one thing you could do here is you could do the iridodialysis repair and then just leave the sphincter muscle blown open. In fact, I would just take a retractor and just trim off all the pigment at the pupil margin, and then you have a nice sulcus to just pop a artificial iris into. But then you deal with the cost of that. Not everybody can afford this.
Or use it in the bag.
Yeah, that's right. I don't like in the bag because, you've seen some of Mike Snyder's cases where the thing pops out of the bag later on, then you have to go back in and pop it back in again. And then if you have any part of the anterior capsule that's inside of the pupil space, that's going to turn white at some point. It's not going to look all that good cosmetically. So I've been putting them in the sulcus for years, and there's basically no issues.
Yep, I think that's reasonable. I usually do a good polishing and put them in the bag, but I think you can go either one. I
Yeah.
got away with that one though, so I was happy not to have the prosthesis.
Yeah.
Sometimes I order them, Kevin, and then I don't use them, and it's like, oh damn, what do you do now?
Okay, great. I thank you very much.
Hey, thanks so much, guys. I'm sorry I have to run back to my Canadian national meeting, but good to see everybody here. Keep well.
Thank you.
Everyone's looking good. Keep on smiling.
You like
Share
amazing
stuff.
Bye.
Thank you. Bye-bye. Well, our next speaker is going to be Dr. Uday Devgan. He's a director of Cataract Surgery Center in Beverly Hills and professor at UCLA and chief of ophthalmology at Olive View, UCLA Medical Center. And he's the cataract coach as himself. So welcome, Uday. Very happy to have you.
Thank you. I have an easy way to fix all these problematic iris cases. I just send them to Kevin Miller, who's just down the street. It makes life so easy. I don't have to do any work. But my talk today is something very fun and interesting. It's the twist technique to explant the lens. You can use a standard incision and no special instruments. This is really a very interesting technique that's so useful in these challenging cases. Now, this is the old technique. You can tell by the standard definition video. This is from about 10 years ago. And what we're used to is if you need to explant the lens through the regular incision, you use these very expensive micro graspers and micro scissors, and you can cut the lens optic in half or mostly in half, and then we can dial it out of the eye. And this technique certainly works. The catch in doing this technique is, well, you're going to damage the central optic. So when you take it out of the eye, let's make sure we don't have any pieces left inside, but also it'd be hard to analyze this lens. If I wanted to see if the lens power was off or there's some other optical defect in it, you really can't analyze it because you've destroyed the optic. In a case like this, if you are going to use the scissors, I'd tell you to first leave the old lens up in the AC, put the new lens in the bag, and then cut it out so the new lens can protect the capsule. But here's the way that I like to do it. I learned this from Jack Chapman in Georgia here in the US. Fantastic technique. I learned it 10 years ago. What we do here is we're grabbing the optic at the edge of the optic, not in the center. We're grabbing the very edge. And this is nothing except for a straight tying forceps. And then the other hand is a cyclodialysis spatula. So the cyclodialysis spatula is used to help roll the lens and to protect the corneal endothelium. Starting with the hand in the supinated position, you turn your forceps, you pronate the hand, and you can see this resident is doing a case, and it's going to be done in 2 steps. And once it's rolled, it can just be pulled out of the eye. So it's an unenlarged 2.75 or 2.8 millimeter incision. And there's the lens completely intact, undamaged. Here's a view outside the eye. This resident was so good that I just videoed this with my iPhone from outside the eye. Let me show you again in slow motion. Grabbing the edge of the optic, the spatula helps to keep the lens rotated and also protect the corneal endothelium. And once you have it twisted enough, it can be pulled out of the incision. Of course, the anterior chamber is filled with viscoelastic. Here, a dispersive viscoelastic. Another video, old standard definition from a resident operating many years ago. This is now a bent tying forceps. It's much easier to use a straight one, but still rotating it, getting the lens curled on itself or rolled up, and then very carefully just pulling it out the incision. And again, very useful technique if you need to perform a lens exchange. So let me show you again. IOLs in the anterior chamber, 1 haptics outside the incision, using straight tying forceps, grabbing the edge of the optic, right at the edge, not in the center. Use the spatula again to protect the corneal endothelium and help you to roll the lens. Start with your wrist supinated, and then pronate, pronate, pronate. You can get almost 300 to 360 degrees, and then pull the forceps right out of the eye, and the lens will come with it. We've used this with AMO lenses, Alcon lenses of the single piece acrylic. We've used Alcon and AMO 3-piece acrylics as well. A silicon lens is another story. It's so slippery, you won't be able to do this. So this is best for the hydrophobic acrylic IOLs, either single piece or 3-piece. And again, 6mm optic or so, it'll come right out that main incision. The one time we have enlarged the incision was we had a very high power lens. The patient had a 30 diopter lens. And so in that situation, we enlarged the incision to about 3mm. But for most lens powers, you can pull it out through 2.75mm incision. It'll come out like this, and then you're basically done. So neat technique. I want to thank Jack Chapman, who taught this to me 10 years ago. And I encourage you, if you have a case of a lens exchange, do this. It'll make your life so easy. And then, of course, at this point, now we can finish the rest of the case. We can do it at high speed. But I want to thank you guys for the opportunity to participate in your meeting. And hopefully you all check out cataractcoach.com. We put a new video every day for the last 800 days in a row. Like I say, my dad didn't raise any lazy kids. Ugly, yes, but lazy, no.
Thank you. Any comments, Kevin? What's your preferred maneuver to extract IOL?
Well, I like to refold them inside the eye as well.
Yeah.
I just think it's a more elegant way. I don't do it this way, but I have some, you know, I've been through every sort of evolution that there is. So I have some old lens folding forceps that we still hang on to. And so I'll just reopen the phaco incision. I'll do an opposite paracentesis, a lot of viscoelastic in the eye. Oftentimes I'll dial one haptic out, put the cyclodialysis spatula under the optic, and then just fold it in the eye, turn it 90 degrees, and out it comes. The one thing you have to watch out for, and Uday, I'd be interested in whether this is an issue with this technique, is when you're folding it, you're kind of increasing the pressure in the eye a little bit. And you have to watch the subincisional iris, because sometimes it'll start to pooch up. If the subincisional iris gets into the incision, you stop. If you pull the lens out, you'll pull iris with it and you'll trash the iris. So as soon as I see the iris coming up, I stop, I let go, I put more viscoelastic in. I'll try it once or twice. And if it's still iris is billowing up, then we're done. We'll just cut the thing.
Yeah, great idea. We put a little aliquot or a daub of viscoelastic on the subincisional iris before we do this. And again, we prefer dispersive viscoelastic because it stays in there better. If you put in the cohesive and those manipulations you do, the AC tends to flatten quickly as all the viscoelastic pushes out. So stick with the dispersive, but great point.
Discovis could probably be a good one here because it's going to give you a little good chamber maintenance and it's going to stick at the same time.
Yeah,
Soledad Romero, do you have a lot of experience? You have talks about the IOL exchange. So
well, I never tried the technique. It seems like very interesting, and I do the old style. It's not so old, no. But my concern is like when I cut the IOLs, I use that with the MST scissors and cutters. Even though the material, you know, they are hydrophobic and they are acrylic, I found like they're like how hard the optics are is different from the alcohol lens. Like I saw that you remove, probably this is an SN60 WF than with the AMO and the Symphony. You know, sometimes the Symphony and the AMO, I had to cut it in 3 because they're not so flexible, I think.
Yeah,
One of the nice things,
go ahead.
One of the nice things about refolding inside the eye is that the intraocular environment is warm. And so the lenses are like, they're very flexible in that warm environment. When they sit out in the operating room on the tray, back in the old days before we had injectors, we'd have to be very careful how we folded the lens because it would just be gone, because they were like steel. But inside the eye, they're like silly putty, and you can fold them really easily.
Okay.
Yeah, we've used this with the Technis ZC Boo, also the ZA 9003. It works equally well. There's no issue.
Okay.
And what about hydrophilic lenses? You can do it with.
I have not had a hydrophilic lens like an Acryos or something to explant, so I've not tried it.
Okay.
If you have to, as you said,
I've refolded hydrophilic acrylics inside the eye, and you can fold them. Some of the older style, like the thermoplastic lens, if you remember that one, the memory lens, those things are impossible. But many lenses you can refold. But I agree with Uday. You cannot fold. You can't refold silicone. It's just way too slippery, and it'll let loose and it'll be banging against things. You really have to cut those, and they're hard to cut because they're so thick. And they're hard to grab onto while you're cutting them because they slip away from your instruments.
Great. Okay.
Okay, we will continue with our next speaker, Soledad Cortina. Soledad is a remarkable anterior segment surgeon, graduated from the Buenos Aires University. She completed her ophthalmology residence at the University of Louisiana and her cornea fellowship at the Illinois University, where she is currently an associate professor and co-director of the Artificial Cornea Program, the Cornea Fellowship, and the Resident Training Program. Soledad, we're very pleased and honored to have you here with us once again. Thank you very much.
There. Can you hear me now?
Yes.
Yes.
Okay.
Perfect.
Thank you so much for such kind introduction. It's a pleasure to be here today. So Dr. Nicoli asked me to try to find a case that combined cornea and cataract. This was his pick. So we're going to talk about Flachsen-Peters anomaly type 2. This is a case we did some time ago, and since then we've done some other cases and have no financial disclosure. So for those in the audience who are not so familiar about what Peters anomaly is, it's rare. It's a rare congenital disorder, and it has to do with an absent endothelium decimate, and sometimes there's also a posterior stromal defect. And the etiology has to do with an abnormal migration of neural crest cells to the posterior cornea during development. There are two types. Type 1, it's the corneal opacity, which is, we call it an opacity, but it's really corneal edema, focal corneal edema, because of the absence endothelium and adhesions of the iris to the cornea. And in the type 2, we have cataract and adhesions of the lens to the cornea. So most of patients with Peters type 2 will either be born with a cataract or develop it pretty early in life. And the challenges in approaching these cases are obviously the cornea is opacified, so visualization is not good. There's stenting, like you can see in this OCT of the capsule. There's also, there can be traction of Descemet's membrane, so you worry about worsening the corneal edema and the opacity. So as a result, many patients don't have cataract extraction alone and may need to have a penetrating keratoplasty together with a cataract surgery. Unfortunately, when you do PKPs in babies like this, their prognosis is pretty poor. So I think attempting cataract extraction alone, if there is some clarity to the cornea, is always preferred. So our guy here is a 6-year-old boy that had worsening vision. It has bilateral Peters anomaly, so pretty bad vision in the other eye after multiple surgery. So this is his good eye. We definitely don't want to do a transplant. And you can see that he dilates and can get let me stop the video for a moment. You can see that he dilates and there's some clarity of the cornea, you know, with the pupil. So he can get some vision around the opacity, which is important. So we're going to try to do a femtosecond approach to try to get around the difficulties of capsulorhexis. So here we're starting to dock. Docking has challenges in a 6-year-old person, particularly with a steep cornea. And you can see how the anatomy is abnormal. So we're not longer looking here when we're trying to set the capsulorhexis, but we want to make sure that it's actually, you know, intersecting on the lens capsule on this image in the OCT to make sure that we have it where we want it. And we also want to just get outside the opacity. So we chose about a 5.5 millimeter capsulorhexis, and then we also want to get out of the posterior synechia here, so kind of right in the middle. We deliver the treatment. This patient is actually under general anesthesia, and you can see there are some bubbles because of how steep the cornea is. Now we're going to transfer our patient to the main operating room. So There's a lot of coordination going on with the anesthesia team here as well. We decided to aspirate, we decided to cut the remnants of the anterior capsule that were attached to the cornea with a vitrector and then aspirate the lens bimanually with irrigation and aspiration. And then we're gonna inject a 3-piece lens in the capsular bag. We decided against initially a posterior capsulotomy. Now we're trying to trim a little bit more those remnants of the capsule that are attached to the cornea. And then we finished the case, and this is how he looked. He went from count fingers to 20-100 at distance and near. And this is his post-op OCT. You can still see that the cornea is thick. He still has edema, but significantly improved vision. So a few things to talk about the difficulties with docking. This is an image of when I first docked and I got a huge bubble, and it took me a few attempts to get suction in this patient, so I didn't want to lose it. So then we had to maneuver the bubbles out, and we decided to do the treatment once we saw that although there were some bubbles left, we could safely deliver the treatment. And then not to always show things that work, you know, because I saw a comment on the chat, oh, you know, all these difficult things seem so easy on expert hands. Well, I think we all do plenty of things that don't work. And so this is, sorry about that. So this is another case of a patient with Peters type 2. And you can see how different this case is. It's more advanced. The opacity is not so central. It's more to the side, but the cornea is all diffusely opacified. The pupil is more involved. And so as much as I wanted to try to get a femtorexis here, the pupil is too small, the space is too little, and I didn't think that the treatment will be delivered efficiently through the opacity like this. And you can see here how very little space, the treatment almost gets into the cornea and the iris. So we decided to abort this case and do it manually. It was a long surgery with, you know, intraocular chandelier trying to, you know, visualize better, but finally we ended up with a lens in this case too, which was good. So special considerations, I think the location of the when you're doing pediatric cataract surgery and you want to use the femto, all these cases under general anesthesia, so you have to think where your femto is located and where your main OR is located. In our case, they're in the same floor, but they're separate rooms. So transporting the patient needs to be planned. Then the difficulty docking because of the steeper cornea and the size of the patient interface sometimes might be difficult depending on the age of the patient. And then what always, I think when you're doing pediatric cataract surgery, consider a primary posterior capsulotomy depending on the age of the child, and always make sure those wounds are very well closed. And thank you.
Thank you, Sole. A very hard case, very challenging case. Dr. Miller, you have experience with femto, with flax. What do you think about the all the cornea alterations and the docking?
Well, this is a really great case, a very interesting case. And congratulations, I thought it was really well done. Yeah, so there's a whole bunch of concerns that you mentioned. One is it's just the logistics of it. You know, we're fortunate we have our femto lasers in the operating room, so we don't have to move people. But if they're under general, you're going to have to move a ventilator and the patient, you know, down a hallway from one room to the other. That takes a lot of doing, because most ventilators, when you unplug them from the wall, they turn off after a while. So you don't want that to happen. Obviously, you probably just bag the patient, but you know, you have to do that. You have to consider that. Then you have to figure out how you're going to dock the patient under the femto laser. I have done maybe 20 general cases under femto, and so generally they go okay. You have to have a, you know, the part that comes out of the mouth has to have a 90-degree adapter, so it's not going straight into the docking apparatus. Those are minor details. The bigger issue is under general anesthesia. Sometimes the eye doesn't want to point straight. It's like it's up here. So then you have to get the head like in some funny position so that you can actually do a square dock, or you have to grab the eye and kind of pull it to where you want and then try to dock at the same time. So those are some of the challenges of docking under general anesthesia. I have a question for you. So the cornea is still, as much as you made it better, it's still screwed up. So are you going to do a DSEC or a DMEC at some point to help with the corneal, you know, edema?
Edema. So I think the opacity is stable and the patient's vision is stable. So we decided to leave it for now. In my experience with these child corneal opacities, I think the more we do, they end up with worse vision at the end than if we didn't do anything. So I feel like this is his good eye. He's got good ambulatory vision, you know, reads. So we decided to leave it alone. His other eye was actually more advanced disease, and he had a rotational graft, then he had multiple PKs, and he's ended up with a retinal detachment and LP vision. So we're playing it more conservative. I think eventually down the line, endothelial keratoplasty would be less risky, and now that he's pseudophakic would make more sense.
Amazing case, Soledad. Congratulations. I have a question. What do you suggest to us and to the audience when you have to deal with these cases, corneal opacities, and you have to improve the visualization for the cataract surgery? Do you use the chandeliers or the light pipe of the machine?
The light pipe from the retractor, I mean, I always have the Parspana retractor available, and I think that light pipe is very helpful. The chandelier as well. That second case that I showed, I think, you know, most of the surgery is almost done blindly. Like, you think you got the rhexis, you think you got most of the lens material, and you think the lens is going in somewhere, you know. I think, yeah, I think you do what you can, and then if you can't, then you have to take the cornea off. So you have to be prepared for both. And that's what we always have, you know, corneal tissue as a backup. But I think if you can get away in these cases with a stepped approach, I think it's better for what I said. You know, the rejections and the failure rates of transplants for these kids is so high that if you can avoid them, that would be better. But sometimes you definitely have no choice.
And Sole, your first approach in this case is to do flex, and then, or your like selection of cataract surgery is different? So,
I mean, for pediatric cataract surgery, and I don't want to say that I do a ton of that, but I mean, you can, if you do it frequently, you can get the rhexis has its challenges just for straightforward cataract surgery, but you know, you can start small and end up with a good continuous rhexis, and I think pediatric ophthalmologists and everyone are quite good at that. But I think flex does add the ease of it. Now you have the exact size that you want, and you can be, you know, confident that you have a lens in the back, which is important for patients that, for example, pediatric uveitic cataracts, where you don't want a lens in the sulcus and things like that. For Peters, I think that the conditions have to be perfect. Like, you have to have a central opacity, you know, for these type 2 Peters, you have to have a central opacity so that you can, because the flex will not deliver a consistent treatment through the opacity. So then you can end up with tags and radial tears. So you need to get outside of the opacity, inside of the iris. So it kind of has to be the perfect, you know, the perfect conditions for you. But I think it's something to think about. If you can use it, I think would be helpful.
Okay, thank you, Soledad. Well, next speaker is Dr. Kevin Miller. He's Chief of Cataract and Refractive Surgery Division. He's director of the Anterior Segment Diagnostic Laboratory at Schulstein Institute and Eugenia Institute. And I have the chance to spend with him a year doing an international fellowship of cataract surgery. So Kevin, welcome. Thank you for being here.
Works better if I unmute myself. So thank you, Manuel. This video I'm going to show is really not a cataract video. It's more of an artificial iris case, but it's an interesting case. In fact, we just got a paper accepted by JCRS looking at artificial iris exchange. So I've been doing this enough now that I have patients that come back saying, you know, they're not all that happy with the cosmetic appearance of their first iris and they want a different iris. It's like the patients that want to exchange their monofocal lens for a multifocal lens. So this is going to kind of step through some of the issues, and all these cases are super complex cases. So just briefly, this was a young woman who, when she was much younger, was bit in her right eye by a dog. She had a rupture infranasally on the iris. Most of the iris came out in the accident. Her lens capsule was ruptured. She had a surgical repair. The rest of the lens material was taken out, and she was left aphakic with a lot of lens capsule in the eye. And then ultimately she had a capsulotomy and then wore an aphakic contact lens, which was sort of custom painted. But it was a thick aphakic contact lens, an artificial pupil that she wore for many years, but it was just really difficult after a while because it was so thick. So that's when she first presented to me. So let me share my screen and show you the video. So I think this is my second case of artificial iris exchange. So this is how she presented maybe 15 years ago. You can see the pacified lens capsule, the opening in the capsule, a little bit of residual iris down there. And you can imagine the glare sensitivity that she would have experienced with this. So at the time I was doing Morture iris devices, and this is a Morture 67B, we put it in. It's an extra cap size incision, it's non-folding, but she had a really great optical result with this. And then for many, many years, she did well. Subsequently, though, she developed glaucoma, had an Ahmed glaucoma tube shunt put in. You can see that in the supratemporal quadrant, and her cornea failed after that. So she came back with a failed cornea, asking, if there's something we could do to help her cornea. And then her vision was hand motions, pressure was good. And she said, is there any way that while you're in there doing the transplant, you can also make my eye prettier, by maybe exchanging it for those new fancy irises? So here's the cornea coming off. There's a retrocorneal fibrous membrane you can see here. But the Morture implant looked like the day I put it in. It was really quite beautiful. I just passively fixated it in the ciliary sulcus. And so now I'm going to take it out, maybe 10 years after I put it in. It was actually relatively easy to get out. It was a little bit fibrosed into the sulcus space, but it worked itself out actually quite nicely. You can see it's kind of encased in fibrous material right here, but it eventually just popped out. And you can see there's a retro iris or retrolenticular fibrous membrane also, which we had to cut out. And you'll be able to see the tube shunt there. So at this point, we're ready to put the new iris and lens implant in. So I've already sutured the replacement lens to the back of the iris, and I've already created Hoffman pockets. And back in this era, I was using more ninoproline. I've subsequently gone more to Gore-Tex now. But here we are, we're suturing through, so basically through the open sky, through the Hoffman pockets, both sides are done. And then I'm just going to dunk the iris and lens combination into the eye, and then we'll just cinch up, we'll pull up on the sutures. And I brought the tube shunt anterior to the iris so that we could actually see it, because it was buried behind the implant previously. And it's really difficult to center these devices. You think you have it pretty nicely centered, but then you don't really know for sure until you get the cornea back on, you pressurize the eye, and that's when you really find out whether you're centered or not. And by that point, it's too late. You can't go back and undo the cornea and redo the sutures on the iris. So you just kind of keep your fingers crossed. The beauty of these Hoffman pockets is, it's very, easy dissection. You don't have to close them. So here we are finishing up the transplant part. And then here she is 3 months post-operatively. You can see cosmetically, you can't do much about the peripheral corneal scarring, but the center looks good. And she's got a brown iris now. And 1 year after surgery, when all the sutures are out, her uncorrected visual acuity was 20/60, so not bad. And their corrected vision with glasses was 20/32 with that manifest, so not too bad. And pressure was good at 10. And I sent her off for a rigid gas permeable contact lens, which I assumed was going to get her close to 20/20. And I actually didn't see her after that. So and she moved from California, where I had been caring for her, over to North Carolina. So that made it difficult to sort of follow her. But that was the case, and it's actually one of the very few cases in the world of artificial iris exchange. I have actually 5 of these cases now, and again, as I mentioned, they're going to be published in JCRS momentarily. So, these are odd things, but something to think about. I mean, just thinking about an artificial iris device in the first place, and then I think increasingly, just like we do lens exchanges without really thinking too much about it. I think this will be a much smaller crop of patients, of course, but I think we're going to see more iris exchanges happening down the road.
Kevin, do you use now Gore-Tex for the sutures?
You're muted, Manuel.
Oh.
He's asking if you use Gore-Tex.
You can hear me now?
Oh, there we go.
Yeah,
Kevin's
yeah. Do you use Gore-Tex to do that, to suture all now?
I do both now. If you look at the package insert for Gore-Tex suture, we talk about things being on label and off label, right? In the United States, where we have the FDA, which determines labeling. The Gore-Tex suture says not intended for ophthalmic use. So it's not off label, it's actually anti-label. It's actually, you're doing the wrong thing if you use Gore-Tex suture in the United States. But it's become kind of the suture of choice for suturing lens implants and irises in. So I think most of us have gone to using Gore-Tex now. I wish there was a smaller gauge of Gore-Tex. So the stuff we have is like rope. It's just way too thick. And I wish it could, we use CV8 Gore-Tex. I wish it was a CV10 Gore-Tex. And there's a big enough community of ophthalmic users of Gore-Tex that if one of us gets sued, I think the rest of us will come to their rescue in a court of law. So Uday, you must be using Gore-Tex also. So
yeah, we use the Gore-Tex to suture IOLs to the sclera very frequently. So at all of your teaching hospital, probably one every other month. And we have a new way now too, where we bury the Gore-Tex intrasclerally. So you don't see those two bands of Gore-Tex under the conj now for 4-point fixation. It's actually within the sclera, the pass. I have it up on Cataract Code. Just search for Gore-Tex.
Oh, I look at the video because what I've been doing is sometimes I put a half moon patch, like a cryopreserved cornea, over the Gore-Tex knot.
Oh, we got a better way.
Yeah, I'm going to look at your video.
I learned it from a retina surgeon. It wasn't not my brilliance.
I have a question for Dr. Miller. Did you decide to do a PK because you thought that cornea was way too gone, or that was the plan because you needed to explant the mortar implant?
There was stromal scarring in that cornea, so an endothelial keratoplasty wouldn't have done it. Yeah, so I just recently had a Gore-Tex suture knot that exposed, and I covered it with one of those half moon corneografts, and it looked really good at the end of the case, but then there was a step right at the limbus, and now the patient has this horrific delum that I can't get to go away. So now I'm going to have to take her back and reposition the half moon corneograft. So it's just like one thing leads to another thing.
Intrascleral Gore-Tex pass.
Kevin,
when you have those going through, these irises are very sticky, and it's hard to rotate the suture through the iris.
Oh, you don't have to rotate it. You'll see the video. You actually pass it first intrasclerally, and then bring all ends out, and then suture it. So you don't have to rotate it to pass it.
Okay.
I learned it from Pradeep, from a UCLA retina surgeon. He taught me.
Okay. Kevin, did you do anything with the tube, with the AMET tube? Did you cut it or
trimmed it back? The tubes are graft killers, so trimmed it so that it's outside the graft host junction.
Okay.
I trim almost every single tube when I go into these eyes to get it. You don't want to trim it so close that if they rub their eye, it's going to externalize. So you can't trim it too much, but you want it outside the graft host junction.
And you didn't have to do a vitrectomy because
I had done a vitrectomy previously. So there was
previously. Okay, great. Well, we keep on with Dr. Pedro Enriquez from Brazil. He's gonna show us a modification of the 4-flange technique from Sergio Canabrava. So Pedro, you're very welcome.
Thanks. Let me just share my screen. Also, good morning, everyone. And I would like to thank Dr. Nicoli and congratulate him on organizing the Ophthalmo League and all the others involved on the organization. Thanks for having me. It's an honor to be lecturing in this session with Dr. Kevin Miller, Dr. Ike, and all the other speakers. My name is Pedro Henriques, and I'm staff of Glaucoma and Cataract at the Santa Casa de Belo Horizonte. Today, I will speak to you on the recent innovations that I have been developing on the previously described 4-flange technique, which has been described by another Brazilian, Dr. Canabrava. The idea for the four-flange technique derives from the 2016 Yamani's paper on the double needle technique, which was a landmark on the scleral fixation surgery. And for me, another landmark in the scleral fixation is the description in 2017 that we can use a 5-0 or 6-0 purlin to create an adjustable suture with flanges. First, the idea was restricted to fixating CTS in subluxated cataracts, the double flange technique. Subsequently, the four-flange technique appeared and showed that we could also use the adjustable suture for IOL scleral fixation, such as demonstrated on this video. And it's also important to remember here that the four-flange idea is also inspired in the first description of an IOL scleral fixation by Dr. Enrique Malgran, an Argentine colleague. And the success of this adjustable suture became even more evident when in 2019, 5 other different applications were described using this technique, such as to repair iridodialysis, fixate artificial iris, and reposition of displaced IOLs. And what I would like to emphasize here is that all of these techniques perform the double flange suture as originally described, placing the prolane in the needle lumen inside the eye, increasing intraocular manipulation and its risks. So, is there a way to facilitate and decrease the risk of this adjustable suture and consequently improving all these techniques that use it? Let's briefly review the original double flange suture. Here in this video, you can see as the prolene is placed in the needle lumen inside the eye as originally described. However, we should keep in mind that this step can sometimes be difficult to execute, especially for surgeons that at the beginning of the learning curve. In addition, greater intraocular manipulation also increases the risks. Moreover, depending on the angle formed between the needle and the main incision, as seen in this video, this stepping can be even trickier. Those were the challenges which led me to think of other modifications to address. What if we put the suture through the needle while still out of the eye and insert them simultaneously into the eye, simply pulling the suture through the main incision afterwards? So the idea is to place the prolene in the needle lumen still outside of the eye. Then we enter in the eye with both together. And finally, I pull the suture through the main incision and the needle through the sclerotomy. We have been testing this modification for over a year. And in this sample video of one of my surgery, we briefly show how it works. First, we put the suture through the needle. Only then do we introduce both simultaneously 1.5 millimeters from the limb. Now we can pull the suture through the main incision and safely remove the needle. The whole process is repeated from the other side. And from now on, the surgical steps follow those originally described. We pass the prolene through the IOL and then guiding it with a needle, we pull it out again. Then we place the IOL inside the eye and pull out the last tip of the prolene. Now we position the IOL and cut the two bottom prolene ends, making the first and second flanges. On centralized, we cut the two other ends of the prolene, making the third and the fourth flanges. Finally, we place them inside the sclera, ending the surgery. However, my experience with foldables IOL is still limited to the aqueous lens. Despite that, we also have hydrophobic IOLs with similar designs, such as Physio and Artis from Crystalens, that can also be used. As a final message to our viewers, I would like to raise the question of which among all the techniques options, Agarwal, Yamani, Malbran, or Canabrava is the best. For me, the true answer is the one you master is definitely the best for you. From my experience to those starting to perform the 4-flange technique, this modification greatly helped me at the beginning. Something else to consider here is the ready availability of the Prolene and its low cost, which can be a huge difference to other options such as Gore-Tex. Thank you all for your attention.
Thank you, Pedro. Great presentation. I think you're making more safer. I think the technique of Sergio. Kevin, any thoughts of this technique? Have you tried? You know Sergio, obviously. I have a picture of you with Sergio sharing an apple rice. Yeah.
So I think one of the last comments you made was, the technique that you have mastered is the one that's going to be best in your hands. And so with all of these things, and there's been a proliferation of new fixation techniques, over the years. We don't have follow-up on any of these things. We do have 25-year follow-up on suture fixation now with Prolene sutures. And we know for the most part that Prolene sutures actually do extremely well long-term. But all the other techniques we don't know. We have 30-year experience with anterior chamber lenses, so we know that they do well if they're sized well. The jury's not going to be out on these techniques for a long time. I have begun seeing complications of Yamani fixations. I've seen the flange in the tear film, on several occasions. I've seen irritation of the conjunctiva, looks like a suture granuloma, where those little terminal bulbs are. So these flange techniques are not without their own set of complications, but because it's all brand new, or relatively brand new, we're not seeing as many complications. But give it some time, and this will fall into disfavor, probably just like everything else does. But maybe not. That's the thing. I think we should be open-minded. We should be looking at patients not just 6 months out in Europe. We should be looking at them 5 years and 10 years out to see if these things stand the test of time. Prolene haptics have not really stood the test of time. There is a slow, subtle degradation of Prolene. And in many of those lenses that had Prolene haptics early on, they've had to be explanted because there's late dislocations of the lenses where they dissolve at the optic haptic junction. So will that happen with these flange techniques? Don't know. We'll find out.
And what's your technique of scleral fixation right now, Kevin?
So my preferred technique is still to suture, but to suture with Gore-Tex.
Okay.
Again, Gore-Tex hasn't been around that long either, so who knows? I think in the cardiac literature, though, it's been around well longer than we've been using it, and it seems to have withstood a decent amount of time there.
Uday, any comments?
We've tried all of them, and I saw one patient with a Yamani exposed bulb that came through the conj. We're doing now pretty much only the Gore-Tex. Okay. And then again, we use the modification described by Jam and Brown, where the Gore-Tex passes within the wall of the sclera.
I wanted to add also that Prolene does differently depending on the material that's in contact with. So when we used to suture more like those PMMA lenses, like the CC70 through the eyelet, I think that erodes more. And I've seen many, broken sutures for those. But, for when we use it to suture, the pupilloplasters, or to suture to the iris, or to suture a modified 3-piece lens, those I haven't seen, the suture breaking so often or even at all. So I want to say that, you can select the cases and then select your sutures too.
Yeah, when sutures, when 9/0 and 10/0 sutures break, I don't think it's because they're dissolving. It's because there's just a constant movement of It's oftentimes it's the suture's been passed through one of those suture fixation eyelets on the end of the IOL, and those things are drilled, so they're very sharp on the edges, and that lens is just constantly vibrating a little bit. Over years, it'll just cut through the Prolene suture.
There's a quick picture right there of the traditional way that they're doing and you see the pass of the Gore-Tex. That's the traditional way. The one I learned from Jam and Brown here is you're passing this Gore-Tex within the sclera.
Oh.
So there is no exposure. So when you see a patient post-op, the knot, of course, is just inside the sclera, and there's no band at all that's visible.
Okay.
Pedro, amazing presentation. Congratulations. Did you have any case of exposure of the Prolene?
Yeah, that's something that I was going to say. That's really some problem that we have, especially at the beginning of the surgery. In the first case, I made big flanges, and they get out of the sclera. One case I have still a big problem with the conjunctiva, and I have to go back to the OR and cut but it's easy to resolve this problem. I cut the flange, make a small one, and replace it, and it's okay. The patient is okay. But it's really one problem that we have, especially in the beginning of the learning curve. You can't make a big flange.
Thanks.
Okay, thank you, Pedro. Well, we will continue with Soledad Romero. Sole. She's a cataract anterior segment surgeon in Baltimore, and she has a lot of experience in secondary IOL implantation, IOL exchange, and iris repair. And she has an instructional course at the AIO talking about IOL exchange. So, Sole, you're next. Welcome. You have to unmute.
Turn on your mic, Sole.
Okay, ahora sí, ¿no? Yes?
Yes.
Okay, thank you so much. So it was a perfect timing, because what I'm going to share with all of you is my learning technique. We were talking about different approaches for a compromise or absence of capsular support. There are many, and there's still like a new techniques coming, and ones that we have more experience, more data and more, longer follow-up. I thought, very interesting, the glue IOL technique. I've been doing for more than 4 years. I traveled to India to learn this technique with Dr. Agarwal. And I think one of the limiting factors is that these techniques are difficult to learn. They have a steep learning curve, and some people, they get discouraged when they have complications. So I want to share, my complications during my first few cases. So whoever's interested to learn the technique, maybe can go the steps that I went through. So every time that we are learning a new surgical technique or we are learning surgery, we think that there is a steep curve, and it's a plateau, and then we are all great surgeons. But in reality is like, when we are supervised, the learning curve is very fast. And then when we are by our own, we face different complications and we learn from them. And that's how we grow as a surgeons. So when I returned from India, I felt like kind of like Lou in this video, that she felt like it was easy.
You share
your screen, please, Sole.
You share it?
Yeah, you have to share your screen.
Listen. No coming?
You have to share your screen first.
Okay, so the glue IOL technique, the basic technique is what happened?
Sole, we can't see your. We can't see your screen.
You can see?
No, we cannot.
Okay, let me share again. Sorry about that. Do you want to go through the next one? Okay.
Just at the very bottom, it's the green thing that says share screen. Just tap that.
Okay, I do share screen.
Yeah.
There.
No.
Share. Okay, I know what to do. Okay. Now share.
Yeah.
Yes.
Okay. Okay. Now it's working.
We cannot see
Sorry
anything.
about that.
Yeah.
Now
It's there. Now it's there.
Okay. Go to the next one. Oh, it's there?
Yes, we can see your screen.
Okay, sorry about that. So, okay, let me move forward. Apologize. So, what I think I was describing this part. So, the technique consists in create two scleral flaps, scleral tunnels, sclerotomies, through where we externalize the haptics through these sclerotomies, and we use the handshake technique for a manipulation of the lens. And then we tag the haptics through these scleral tunnels that will help us to centralize and keep the IOL stable. And we glue with thrombin and fibrin organic glue. We seal the scleral flaps. So when I came back to the US, I felt like I knew everything. And my first mistake, I did an improper sclerotomy. So the sclerotomy, the entrance was too soon. So I damaged the ciliary body and have some, bleeding into the anterior chamber, and also a little bit of vitreous hemorrhage. But it was easy to clean. So the correct way to perform this sclerotomy is to go first perpendicular, and then we go parallel to the iris. So we have to pass the ciliary body to prevent to damage, and have any bleeding. Then, while I was in India, one of the most challenging steps on this technique is how to create appropriately the scleral flaps. So the first tip is to hold the eye, secure the eye during the procedure, stabilize the eye. Then try to use instruments that are new and sharp, not like those ones. And then it's more important, as you can see there, I'm putting all the pressure on the tip of the blended, the crescent, and still on the base. So the scleral flap is very thick, and the scleral bed is very thin. The problem comes when I perform the sclerotomy, there is prolapse of the ciliary body. And so what I did, with the crease, we stop the anterior chamber, and we suture with a 10-0 nylon the sclera, and we make the sclerotomy small, and we still were able to perform the glue IOL technique. The only extra step is still only glue the sclera, we just add a 10-0 nylon. You can see that the iris is rounded, and the pupil is very well centered. So what I learned after that scleral flap is how properly perform the scleral flaps. So I use sharp crescents. I use the scleral, the Argawal glue IOL marker. I delineate with the tip of the blended crescent. I try to delineate and go a little bit deeper than the thickness of the scleral flap. I hold the eye and stabilize the eye with a colibri forceps. And then you can see I make this like a rock the angle crescent with the pressure on the base of the crescent and still on the tip. In that way, I just keep the same depth of the scleral flap. And another challenging steps is the handshake technique. We know that the haptics are strong, but they're some kind of fragile. So here I was trying to manipulate the IOL through the haptic instead of using a Harris hook or something to expose the other edge of the haptics. And what happened is like the haptic broke and I have to exchange that IOL and just complete the case. So I learned how important it is to be gentle with the scleral, with the haptic manipulation. And so what I do is like the handshake technique where I alternate the grip of the length of the haptics. These are epsilon microforceps. I use this MST and I grab the very tip of the haptic and I externalize it. And this time I got smart and I use like iris hooks to expose the lens and to have a good visualization. And when I externalize the other haptic, I perform the same handshake technique where I'm going alternating the grip through all the haptic because I don't have any capsular support. I just want to be very gentle. I grab the tip and then in order to secure the IOL, you will see I grab the externalized haptic with the forceps. So when I pull, I don't pull the whole iris. And I have another case where I have more experience to performing this handshake technique. So even with a small pupil, I'm able to, to manipulate the lens. But in this case, I have a good visualization of the haptic and I can externalize. I recommend to use microforceps. There are different brands. But I prefer the ones that are like kind of angled, the ones that are curved. And I also prefer the ones that they don't have, like they're not serrated, they're like kind of flat. They can cause sometimes a slippery of the haptics, but they will damage the haptics in less opportunity. I have a great, this is my technique to go when I have to do like some IOL fixation, without capsular support. I do Yamani, I do, I suture, but this is my technique where I feel that I can give the best to my patients. And this technique, it had been described in 2007. So there is more than 10 years of follow-up in some of the cases, okay? Thank you. Any questions?
Thank you. Thank you, Sole. Kevin, any thoughts?
Well, that's a really good cases. I'm curious as to where you found the four fixation hole IOL, because I haven't seen that in like 20 years. That must have been in India.
Oh, well, that was the case done at Wilmer.
Okay.
It was
the lens was already in the eye, and you just refixated.
Yeah, that patient was done like 20 years ago, and dislocate the resuture to the iris. And this, dislocate again, and that's what I did. I do the glue IOL. Yeah, it was for many years ago. And what I noticed is those iris fixation is like the chafing. It's not like only the cause, the syndrome, with inflammation. Really thin the iris stroma, okay, and that's make loose. So I think a scleral is better than iris suture.
Yeah, so when you're doing any of these fixation techniques, and including interscleral haptic fixation, I think we should get away from the word glued IOL, where the glue is gone in 2 days. So it's really it's the interscleral pressure on the haptics that are fixating it. And then we have 2007, but we don't have like super long-term follow-up. So is somebody that's doing this to their eye for the next 10 years, are they going to back that thing out and it's going to be inside the eye? There are case reports of that already. You have to make sure you're not, when you're tunneling the scleral tunnels, that you're not making them too large so that the haptic will back out of there. And you have to make sure the angle is correct. You do have to be concerned about eyes that are quite large, because you're not going to have a lot of haptic to feed into the scleral tunnel. So you always want, no matter what your fixation technique is, you want to make sure that the anterior edge, because almost all of these three-piece lenses have square anterior edges. You want to make sure that that's way away from the iris, because you may go through all this work and 5 years later, the patient's going to be back in the office with bleeding and pressure problems and all kinds of stuff. I've seen that a lot with the acryos lenses. It seems like with the retina community here, suturing acryos lenses to the sclera with Cortex, that's their thing now. And I'm seeing a boatload of patients coming in with aqueous lenses and big time UGG syndrome that I'm having to take out now. So all these things, they have their upsides and they have their downsides. And I like this so-called glued IOL technique, but you have to make sure you don't, all the things you mentioned, you can't kink the haptics, break the haptics, can't have them too stuffed into too short a tunnel, and on and on and on. You don't want the eye super hypotenuse in the immediate post-op period either.
Yeah, and they're like difficult techniques, you know. I mean, they're not easy to learn. Something interesting, I was participating in another webinar in Europe last week, and there is an implant from Italy called Carvioli, that is an implant for the sclera, and they're like doing the surgery. So when you don't have it, it seems like it's nice.
It would be nice if somebody made a haptic material that was sort of porous, like hydroxyapatite, you know, maybe at the ends that tissue could grow into and then really lock the thing in. But so far, I've not seen that on the market anywhere.
Thanks.
Brilliant presentation, Sole. Thank you very much. Thank you for sharing with us your tips and in your learning curve.
Yeah, don't criticize me.
No, it's the best way of learning. We learn from mistakes.
She's terrible, don't go.
Incredible. Thank you very much. I have one question for you. You always enter with the 27 gauge, 1 millimeters from.
Yeah, it depends on what I do. What I did so many now that I have like a table depends on the axial length. Because here in Baltimore, there's a lot of African Americans and the eye is very long, you know. But yes, it's 1 millimeter, 1 millimeter 0.5. And they always ask me what is the power of the implant, if I use in the back or I use the sulcus. So far, you know, targeting for the back, I have great outcomes. I have a guy coming last week, and he was like a same visual acuity in both eyes, one in the back and the other was in blue. So it was beautiful, you know.
Yes, and how important is to use an anterior chamber infusion? That is
exactly, because sometimes the IOL is fine. Yeah, well, you can have hypotony, but what I've seen is like long term, you have these patients that they're like 20/30, 20/40, but they say, I don't see wall. So what I started doing OCT of the macula, and you can see like this, like a small, like micro folds in the macula. And that's secondary to the hypotomy during the surgery, even they don't develop like folds. And they disappear over time. These like microfolders, they go away, but the patients are like with good visual acuity, but they don't, you know, they read well, but the quality of the vision is not so good. Yeah, a lot of, you know, it's not easy, but this is, you know, it's very interesting. It's fun.
Thank you very much.
One question for Kevin or Soledad or Uday. Are you still using ACIOLs?
Yeah,
yes.
I actually like ACIOLs in the older patients. You know, you just don't want to spend a lot of time inside their eye. You know, so if I have a 75 to, you know, and up, sometimes the easiest thing to do, especially if they have like a ton of regenerated cortex and Sommerings rings, I'll just go in and clean all that stuff out, do a nice vitrectomy, slip an ACIOL in, 3 sutures, close to take the sutures out in the subsequent weeks, and they do well. They do extremely well. Okay. So yeah, but they have to be sized well. That's the key to ACIOLs, is proper sizing. And make sure, no matter how well you think you did a vitrectomy, always do a peripheral iridectomy. I've been burned too many times when I thought I did a great vitrectomy. There's no vitreous, so there's no chance of pupillary block, and next day they're in iris Bombay.
Yeah. Uday?
Yeah, so we're still doing it with the residents in certain cases. Again, if the patient's going to have 10 more years of life expectancy, published studies have shown ACIOL or sutured posterior lenses have the same overall result. So there's no harm in doing a well-done ACIOL. We like to make a scleral incision because it's going to be larger. We don't want to make a big corneal incision. And then finally, for suturing to the iris, the key with suturing an IOL to the iris, there has to be some capsular support. If you can support most of the lens or half of the lens and the other part, then you can, the weight of the lens is supported primarily by the remnant of the capsular bag. Then the iris fixation is reasonable. But if there's zero capsule, don't do iris fixation, because then the weight of the entire IOL is on those 2 points of iris.
And where do you prefer to leave the ACIOL? In the meridian vertical or horizontal?
So that's a good question. 'Cause that's a really important thing. You know, just like anything I learned the hard way, you always orient the haptics away from the incision. Patients will do this and the haptic will be outside the eye. So you put it in, you know, it doesn't matter where your incision is, but once the AC lens is in there, rotate it 90 degrees away from the incision. That way, if they rub, the lens is not going to come out.
Yeah, we try to do a superior scleral tunnel and then placing the lens horizontal, 3 o'clock to 9 o'clock. So it's 90 degrees away. Also, then we have, if you imagine where gravity is, you've got 2 points where the weight of the lens may be rested. But again, these are angle supported. The key, what Kevin said, was getting the sizing right. So we're doing horizontal white to white, maybe add a half or 1 millimeter, and that's about the size of the AC lens. The tough part is making sure your OR has the full consignment of the 3UO, 4UO, 5UO lenses.
Yeah, I will operate on steep axis. If somebody has 2 diopters of corneal cylinder, I'll just take advantage of that because, you know, I can get 2 diopters with a 6 millimeter incision I'm going to need for an AC lens. So I'll go on any axis, and then just make sure you rotate the haptics, you know, 90 degrees away. You can just kind of walk them around with a hook and hook, or you can take 2 hook and hooks and compress the 2 haptics simultaneously and spin it all in one fell swoop. It's easy. You want to make sure that you have to do an iridectomy. You want to make sure that the haptic, the 2 parts that are going to sit in the angle, that they are not close to the iridectomy, because those things will find their way through iridectomies. I've had to reposition a number of AC lenses over the years that were just, they found their way into the iridectomy.
Excellent advice. Thank you, Miller. Thank you, Jay. We're going to continue with our last speaker, Dr. Luis Carlos Escaf from Colombia. He's an excellent young surgeon. Luis Carlos Escaf is performing the last year of his vitreoretinal surgery fellowship at the University of Toronto. Welcome, Luis, and thanks for being here with us.
Thank you. Thank you very much, Guido, for inviting me. And even though I'm migrating to the posterior segment, I had to say yes to these incredible opportunities to share with all you guys. So this was actually a case before I started my fellowship, 75-year-old lady who had motion vision, pretty decent endothelial count, 2,800, and a white, very dense cataract. So the first step was creating a small paracentesis using trypan blue and using cohesive viscoelastic. In this case, it was Provisc. And before doing the main wound, we do with a 30 cc gauge needle in a 1 cc syringe. We do a small puncture in the anterior capsule, draining or trying to drain the material that is causing the pressure in this white cataract. You have to be careful not to move much the needle because that can create a big tear in the. Then we do an capsulorhexis that is about 5.5, 6. You want to do it a tiny bit bigger because it will make it the phaco much easier. After this, the most important thing in this type of cases of hard nucleus is achieving the fragmentation. I use an ultra chopper tip, which is like a modified phaco tip to achieve the fracture. I also use a chopper or a sustainer that is actually not chopping because it's too hard to chop. The chopping is done by the ultra chopper, but it achieves a contrast support that reduces a little bit the sonular tension or the sonular stress with the chopping maneuvers. It's important to really chop this nucleus in many pieces or as much as you can, and at least have one that is small, but because it will help you debulk it easier when you do the phaco. So in this step, if you achieve this, you have to let the machine do its work, use relative high flows and vacuums, which allow you to be more efficient and less reliant on the ultrasound power. The way I configure my vacuum is starting at 300 and then it peaks at 700. But when I have all the pedal pressed down, it goes down again to 350. I think that helps with the surge or prevented the surge. I don't know what the other panelists think about that. I would like to hear their opinions. After that, halfway through, it's important to insert viscoelastic. If you are able to do it without removing the handpiece, it's easier because it will prevent iris prolapse or the shallowing of the chamber. And after that, continue with the phaco. One thing that I have done with time is that after I have been finalizing the phaco or in the last few fragments, I like to switch to epinucleus, which is a setting that has lower vacuum and lower flows than my current fragment removal settings, and it reduces the chance of having posterior capsule rupture at the very last fragment of the surgery. So we can see that we achieve removing the whole nucleus, having a decent corneal transparency, and achieving a lens in the back at the end of the case. So that was it.
Beautiful case, nicely done.
Thank you.
Kevin, how do you approach white cataracts? Do you do a puncture first? Do you jag, laser? What is your?
Well, lately I've been using a femtosecond laser. I think that actually helps. You know, there's a good study by Titiwal out of India says that about 55% of those will be complete, and the others won't be. But when they're not, and this has been my experience, there's like little postage stamp things, and then you can usually just complete it, and it'll tear very nicely. You'll get the exact same femtosecond, cut that you would have gotten if you had completed with the femtosecond. So that's been my approach. And that the beauty of doing that way is that the eye is pressurized the entire time. So you never have a situation where it's shallow, where that fluid that's in the lens is going to push out and it's going to cause the thing to radialize. So I think that's been my approach. But when I don't have that, or when somebody can't pay for that, then trypan blue and over pressurize. You want the pressure in the anterior chamber to be basically equal to the pressure in the interlenticular space, so that there's no balloon pop to send the rhexis out. One thing I would say, is it possible to go back to the video? Because there's a couple of things I thought I would just sort of,
yeah, of course,
give you some my thoughts. At the very beginning, you have the IOP. If you go way to the beginning, you have like a 28, yeah, right there. In the top right button, it says the IOP. I don't know that there's any value of varying the IOP inside the eye based on the foot position. So basically, on position 1, which is irrigation or pressurization, you've got an IOP of 20. And as soon as you get to position 2, you suddenly ramp up the pressure to 60. So that means the pressure in the patient's eyes is going through wild gyrations. If this is under topical anesthesia, this is like super uncomfortable. I think the thing that makes the most sense to me is trying to maintain the same IOP for every step of the procedure, no matter where your foot is. Same IOP all the way across. These ramps on IOP never make sense to me. And the other thing is, look at the IOP here, 105. Yeah, so what's arterial perfusion pressure? It's 70. So we're off the charts here. And that's super uncomfortable, especially under topical anesthesia. So I would say with the Centurion, this thing has really amazing IOP control. And you can work, I'm now working at IOPs, target IOPs of 30 and 35. So there's no need to be on the second floor with the bottle. I mean, this is like the bottle hanging from the second floor, like we used to do in the old days when we had a lot of surge issues. You're not going to get nearly as much surge with this machine. So there's no need to be at these super high arterial perfusion pressures. You can work much, much more safely and comfortably, and you're not going to get that post-occlusion break surge. And that was one of the questions that was brought up. What's the number one factor in post-occlusion break surge? It's the vacuum level at which you break occlusion. That's going to be the primary determinant of the surge volume. So you want to be able to break occlusion at relatively lower vacuums if you can.
Okay, thanks.
Brilliant presentation, Luis. You also have a lot of help with your father's device, Dr. Chopper.
Yes.
But when you don't have that device, what technique do you suggest to us, to the audience, when we have to approach this hard nucleus, hard cataract?
I try to do a modified stop and chop technique, a really deep central, not very wide, but very central and deep crater, and try to support myself there to chop. Yeah, that's what I basically do. But you need to have the sleeve of the teeth really back to achieve that.
Do you use any UVM examination before surgery, or just to see the diameter of the cataract?
Not on a routine, but
Not
I
a
don't know
routine.
the other-
Kevin, Uday?
So if I can't see the back of the eye, then I want to know what's back there before I do surgeries. But you don't need UBM for that, just a regular B scan ultrasound. I just want to know if the retina's on or off. There's a mass back there. You know, I don't think UBM gives you much usable information. You know, looking at the lens itself, unless and here you would use mostly OCT. If it's a posterior polar and it turned white. Actually, if it's a posterior polar that turns white, you're not going to see through it. But if it's a posterior polar and a little bit milky white, it's nice to know whether the capsule is intact behind that little manhole cover or not. And an ultrasound, I'm sorry, anterior segment OCT will often give you that information.
Okay. Uday, you are mute, so unmute you. Yeah.
We're doing a standard B scan for these cases. For most of the white cataracts that we're doing in the teaching hospital, we don't have a femtosecond laser. So there's the femtosecond, what Kevin was talking about. This is in our private surgery center. You can see there's some persistent attachments. And like you said, it's a postage stamp. You grab it and pull it centrally, and you're able to break those and still end up with a normal rexus. But what we do instead is we do either the needle aspiration, which is what we saw here, or we do the baby rexus. With a highly pressurized anterior chamber, higher pressure in the AC than in the bag, via a paracentesis, you can just use a cystotome and make a small baby capsular rexus, 2 millimeters. Then decompress the bag, rock the nucleus, get all the fluid out, and there's no risk of radializing. Now you can make your main incision and then enlarge to a normal rexus. And I agree with what Luis said. We want a 5.5, even slightly bigger capsular rexus. Don't make a baby capsular rexus in a dense cataract. You want to operate through a nice generous one. But the double rexus technique works well.
And just because you get all the milky stuff out of the anterior port lens doesn't mean you're home free. You think, okay, all that stuff's gone. All that stuff that's trapped behind the, you got to rock it and get that stuff around, because that stuff that's behind the nucleus will come out later on, and out it goes.
The best part about these dense white cataracts is whatever you do, the patients are happy.
Yeah.
Everything's an improvement.
Yeah. Yes. That's true. They think they're God. But I propose that we don't call those Argentinian flag anymore. We should let them call Uruguayan flag, you know. We don't want to be related to
all the bad stuff to us. Yeah. Okay, any more comments? Any thoughts? Well, I think in these white cataracts, you don't know if it's going to be a hard cataract or a soft cataract. So maybe in the OR, you see that you're having a very hard case or not. So maybe we try to do a cross with a phaco, try to move the cataract, and then with 2 Kuglens, with viscoelastic, we try to break the cataract. That's the way we usually do that. We don't have the femto, but what about the femto, Kevin, with hard cataracts? Do the femto laser soften the nucleus as much as
these are not white cataracts now. These are just regular, nuclear sclerotic cataracts. Yeah, all the studies, and there's close to 20 studies that look at this. The energy reduction at the time of phacoemulsification is proportional to how dense the cataract is. So in 1 to 2 plus NS, you don't get a lot of reduction of phaco energy, but when you get to the 3s and the 4s, you get a significant reduction of phaco energy applied. So that's where the real benefit is. Now, that's a safety benefit, so you can't charge for that. You can't charge more for doing a safer procedure. It just doesn't look good in court. But the reality is that's where you're going to get your EPT or your CDE reductions is when you get to dense cataracts. Now you do have to turn up, like when I'm doing a 4+ brown rock, I'll crank up the phaco energy or the femto energy maybe 30%. But there's no question that's where the beauty of femto comes in.
Oh, great. Any more comments? So we can say that we are finished So all the presentations were great. And we would like to thank again Kevin Miller, Sole Romero, Uday, Pedro, Luis, Soledad Cortina, everyone. Thank you, Ike. Ike, if you can see us.
Se fue a la
And
playa.
yes, he's gone to the beach. Yeah. And we would like again to thank you all. This was a great symposium, and we would like to do it again. So
Manuel, if I can say something, so you're one of the star international fellows at from UCLA. So I'm really proud of kind of watching your career, and looks like it's really taken off. I see the position that you've risen to with the Argentinian Congress and in organizing these seminars, and I must say I'm really proud of what you're doing. It's really great to watch your career.
Thank you, Kevin.
And also
Thank
he's a great colleague and very humble, you know, besides of that. I like Manuel so much too. You know?
Thank you very much, Kevin, for your work.
Thank you for including me.
You're gonna make him cry, Kevin.
Yes.
Thank you.
Every time, if you want, every cataract symposium, you can be here. It's your house. It's your
I have to get permission from my wife.
Yes. Well, thank you very much, everyone.
Thank you
See
very
you
much.
around.
Thank you to Point Bolivia also, though.
Yes, Point Bolivia. Thank you.
Yes.
Thank you very much.
Thank you, guys.
Bye-bye.
Everyone.
Nos vemos, que le va bien.
Ciao, ciao.
Gracias.
Bye.
Thank
Bye-bye.
you.